I'm Dr. Krautmann. I'm one of the foot and ankle surgeons here over at Columbia Orthopedic Group. I've been here for close to 5 years now, so it'll be 5 years in September. This is a little bit of a talk I gave on some of the very common conditions that I see. Arguably, I guess they're all one condition, they're arthritis, but they affect a lot of different areas of the foot. It's a common thing that I see. And so we'll kind of go through sort of all of the areas where I see this problem and some of the treatment options that I can offer to patients, including non-surgical options and surgical options. So we'll kind of start with the basics. What is foot and ankle arthritis? So loss of cartilage in any joint is basically the definition of arthritis. The vast majority of this is going to be osteoarthritis, which is our term for just wear and tear arthritis. In this area of the foot and ankle, it's going to be mostly related to previous trauma, though some of it is just unfortunately related to time, and occurs without any real known history of trauma. We will see occasional cases of inflammatory arthritis, such as rheumatoid arthritis, lupus, and some of the other rarer causes out there. Though those have actually become a lot or a lot less common due to improvements in medical management for those conditions. So we typically see kind of the general wear and tear arthritis at the joint level. Um, so things that you can do if you start having pain without necessarily having to come see us, anti-inflammatories are a good option. If you have symptoms that have lasted longer than a couple of weeks, maybe 3, 4, 5, at the most 6 weeks, I think it's probably worth being seen. Doesn't necessarily mean that it's arthritis, but it's something that we can potentially offer treatment for. Um, Symptoms on the really short duration, oftentimes we're going to say, you know what, the best option is let's see if this resolves, because a lot of these things are going to be activity related. They'll cause a little inflammation, pain will get worse, and then pain will get better with a little bit of rest and some anti-inflammatories. If you're unable to walk on something, that's definitely time to go ahead and seek treatment. And if you have significant visible swelling at the site, that's a sign that there's probably something more going on that needs to be addressed or at least evaluated. So these are your kind of, again, at-home treatments, anti-inflammatories. Avoiding high impact activity definitely helps. There's plenty of over-the-counter braces and orthotics that can provide some relief. How effective they are truly depends on the condition. And so that's sort of where we start once we see somebody. But a lot of this stuff is something that people can do on their own before they come see us to try to get some relief. And then, so what are the areas we're looking at? So these are kind of the four areas where we place kind of the arthritis as a separate entity, a separate diagnosis, I guess you could say. So ankle arthritis, that's where you have the joint here, the ankle. This is the joint that provides the up and down motion of the foot. Um, the ankle arthritis is going to be pretty common, though mostly related to prior injury. And then you have the joints in the back of the foot, the hind foot. These are the joints underneath the ankle. You can't really see this joint very well, unfortunately, on an x-ray because, well, it's arthritic, but also it's a difficult joint to actually x-ray. Usually we have to get a CT scan to see this well. Um, and then you have the middle of the foot. This is kind of the typical area for pain on the top of the foot. And then the big toe. The big toe, oftentimes this will sometimes present with people thinking they have a bunion, though this is technically a different condition from a bunion. So we'll go through kind of each of these conditions and sort of the treatment options and the recovery process if we are talking about surgery. So starting with ankle arthritis. This is the one where, again, most of these are going to have some history of injury. Doesn't necessarily mean people will remember it, but probably related to history of recurrent ankle sprains or a history of previous ankle fracture. Um, Treatments initially are going to be Again, the activity modification, low impact activities can help a lot. Bracing, we use this Arizona brace fairly often. It is effective, though a lot of people will say it's uncomfortable. That's really a patient-specific option as to decide whether or not they're willing to wear a brace. It Unfortunately, the brace doesn't work if you don't wear it, so you have to be willing to wear it, and it can provide a lot of relief. I will use this one a lot kind of before surgery if patients are considering some of the options later on, which we'll talk about, to give them an idea of sort of what life may feel a little bit like. Injections, I typically will use pretty liberally early on. I use them both as a diagnostic tool to kind of confirm the diagnosis. If I inject the ankle, pain goes away. I know that that's the problem and that's what we need to address. And then shoe wear changes can be made. This is actually one we don't do as much anymore because a lot of the tennis shoes nowadays are sort of made with this rocker bottom style sole, anyways. So a lot of patients are already doing that treatment actually. As far as the operative treatments go, there's really two options. Once you've exhausted all the conservative treatment and you're still having significant symptoms, we go to either ankle arthrodesis or ankle fusion or ankle replacement. This is a pretty well debated topic still in the world of kind of foot and ankle orthopedics. Ankle arthrodesis was definitely the gold standard for really the last, well, basically as long as we've been doing this surgery. Ankle replacements existed a long time ago. They were pretty terrible. Everybody stopped doing them. Ankle fusion became the gold standard, still is the gold standard, arguably, though ankle replacement's probably overtaking that in the last 10 or 15 years. It's really taken off within the last 10 years for sure. The advantages, ankle arthrodesis is stable, excellent pain relief. It's great at controlling any kind of deformity that may have developed over time. It has the lower complication rate once you get fusion. So the goal is to get the two bones of the ankle to grow together. Once they grow together, they don't hurt anymore, and they provide stable weight-bearing limb, basically. Um, they does come with the loss of motion. That's the main downside, obviously, to a fusion, is the ankle doesn't really move up and down anymore. Surprisingly easy for people to walk with and still functional. It's still really definitely the answer for very young patients with arthritis because the longevity of the ankle replacement is the biggest concern. So ankle replacements obviously become much more common now. They're gaining, they've made a lot of improvements in the implants and how we do them so that survival has improved significantly within the last, I mean, even 5 to 10 years with the technology now that we're using. It does spare motion, normal gait pattern, but does come with a higher risk of complications. And I think that the main issue I see with ankle replacements is that the complication never goes away. So with an ankle fusion, once it's fused, it's kind of done. The only downside is some arthritis in joints around the ankle, which tends to take 15 to 20 years to develop. Ankle fusion can be perfect and it'll do great for a couple of years, but it can always fail. And you never really know what the associated cost can be. So it's a little bit of a it's not a time bomb, but it can kind of give you trouble at any point in its existence. And so it has to be this is a pretty in-depth discussion before we talk about surgery, but both of them are very effective at pain control and something that we do quite often. As far as the recovery, pretty much the same recovery. This keeps it simple. So you cannot walk on the foot for 6 weeks after the surgery. Most patients are going to use a knee scooter during that time to get around. These can be done typically outpatient. Patients begin walking in a boot at 6 weeks, get to transition to shoes with a brace at 12 weeks. And I usually will quote full recovery at 3 months, though most patients at the 3 month mark are actually pretty much doing the things they want to do with the brace on. And they're generally relatively pain-free, if not completely pain-free at that point. So then moving on, this is going to be so our hindfoot arthritis. This is moving further out into the foot. So on this x-ray, you can see the ankle here, which looks relatively normal. The joint below the ankle, the subtalar joint, is very arthritic and narrowed. This is a patient, actually, you can see their joint pretty well, thankfully, on those x-rays. This is the joints. There's really three joints that would be included here. It would also include these two joints out in front of the talus and the calcaneus. These are the joints that provide the side-to-side motion of the foot. This is typically very painful on uneven surfaces because you're using those joints to accommodate the ground. And so it doesn't tend to be bothered as much by walking on a flat surface. It's often a main association with flat foot deformity, especially if it's been long-standing. Treatments are pretty similar to the ankle arthritis, bracing, orthotics that can help to realign the foot in the case of somebody with a flat foot deformity. You can do some physical therapy to help with the flat foot deformity, especially if you catch it early, and that can definitely improve symptoms. And then again, injections are used, um, especially in the early treatment. As far as the actual treatments go, the only really viable option for this one is going to be the arthrodesis infusion. There are no replacements for any of these joints that exist. Once you get past sort of the injection or bracing stage of treatment, you have to do an arthrodesis. You don't necessarily have to fuse all three joints. This was done in a case that you can see here with very severe deformity to the joints. And so, in order to realign the back of the foot and get the weight bearing surface of the heel back underneath the leg, we had to do something that would provide all of that correction. And that required a fusion of all three of the joints in the back of the foot. Pretty common procedure. Recovery for this is identical actually to the ankle replacement and ankle fusion recovery. Again, 6 weeks, you're going to be not able to walk on it at all. That's to get those bones to fuse together. 6 weeks walking in a boot. After that, transitioning to a brace at the 3 month mark. And then again, full recovery typically around the 6 month mark. Though, again, most people are really pretty much pain free once they get to the 6 week mark walking in the boot, but are still restricted to some degree until that kind of full 6 month recovery. Midfoot arthritis, again, another very common problem that we see. This is typically going to present as pain on the top of the foot. A lot of people will complain of pain where the shoelaces cross over the top of the foot. There's often an associated little bump that forms over time. Um, and again, non-operative treatment is going to be stiff-soled shoes to support the arch of the foot with an arch support typically will help. I find actually a rocker bottom shoe helps a lot with this one as well. And then I do image guided injections for these joints because of the size of the joints. They're basically about the size of the needle that you're trying to use to do the injection. And the image guided injections can provide excellent relief for anywhere from probably 3 months to a year, depending on the patient. I use the injections a lot in patients on this case for diagnosis. There's a lot of joints that are in the middle of the foot, and the pattern of arthritis is not always the same. And so we will typically inject the joints that clinically appear to be the worst, but also seem to be the source of pain. And if pain goes away, then we at least know which joints are generating the symptoms and we can treat accordingly. Um, Again, with this, the gold standard treatment is going to be arthrodesis. These joints don't really provide any noticeable motion for most people. And so there's really no downside to an arthrodesis, fusion of the joints for this condition. It allows for correction of any deformity when it is present and excellent pain control. I've been doing this deep perineal neurectomy more often recently. It's excellent for very old patients that can't deal with the recovery of a fusion. It's a little bit of a cheat. We're basically going above the ankle and taking out a nerve that provides the nerve supply to those joints so that it stops the pain without having to go through the recovery process of a fusion. It does require an injection prior to the procedure where we basically numb the nerve to confirm that removing the nerve would actually remove the pain, because that's not necessarily definitively the case. The only downside to the neurectomy really is some numbness between the big toe and the second toe, because that's the one area of the body where that nerve um, gives sensation to the skin, but doesn't really provide any other function at that level. It's a purely sensory nerve at the level of the ankle where we do the neurectomy. Again, recovery is pretty much the same for the other um, fusion procedures and the replacement. 6 weeks non-weight bearing, unfortunately. That's definitely the hardest part of the process. 6 weeks walking in a boot, get to shoes around the 3 month mark, and full recovery at 6 months. Again, very successful surgery. There's a very small rate of non-union, which we do everything we can in surgery to avoid, but does occasionally happen and can require revision surgery, as the case with all the other options out there. But very effective at pain control for patients, and really doesn't have any functional deficits once the fusion's healed, given the fact that those joints really don't move at all. And then the last one that we see typically is going to be the big toe. So this is called hallux rigidus, which is a fancy way of saying stiff big toe. That's because this condition, more than any of the other arthritic conditions that we see, is really associated with a loss of motion. A lot of patients will come in and even say, like, I got a bump on the top of my foot and it's kind of painful, but not that painful, but it doesn't move anymore. And that's very typical of this problem. Can be very painful, but oftentimes really just restricts motion. You'll see this large bony formation on the top of the big toe. Oftentimes people confuse that with a bunion, but the location is different. Bunion's really on the inside of the toe, not the top. Um, Treatments, again, similar. Carbon fiber insert for the shoe is kind of the different treatment there that can be very helpful. It's basically just an extension of the sole of the shoe that keeps the shoe from bending and prevents the toe from having to move up and down, which will reduce pain significantly. A lot of running shoes nowadays are actually built with this carbon fiber extension in them anyways, and so a lot of people are treating this already with their tennis shoes. Again, I will do injections for this problem. Definitely get good relief from those. I do those again image guided because of the size of the joint. And then the treatment options, they get two options this time around. So for early arthritic changes, when the arthritis is relatively mild, you can kind of go in and shave down the bone spurs on the top of the toe, and you can kind of clean up the joint. And that's usually very good for pain relief, but it doesn't solve the problem permanently. Again, for the early stages of arthritis, it can be very effective and provide a couple of years to, maybe 5 to 10 years of pain relief. Any of these patients typically will progress in the overall arthritis and ultimately probably be a candidate for a fusion, which has excellent outcomes. You do lose the motion in the toe permanently, but it's extremely effective for pain control. And they've studied this pretty extensively as far as activities afterwards, and patients go back to doing way more than they were doing even before surgery, even though they lose motion because they have no pain. And it's a extremely effective surgery. So recovery from that one is much easier. You are able to weight bear on that immediately. I use this kind of goofy looking shoe that keeps weight off the front of the foot. Some patients will elect to just use a boot because they find it more comfortable, and that's perfectly appropriate as well. That's for 6 weeks, and then we transition to regular shoe at 6 weeks with a carbon fiber insert to keep the shoe stiff. And most patients, as long as x-rays look good at 12 weeks and are healed, can go into regular shoes or be barefoot at the 3 month mark. Um, so that pretty much completes the specifics of the talk. So why do we choose Columbia Orthopedics Group? Well, I think we're the best in town, but obviously I'm biased, but we've been around for a long time. We've got excellent outcomes. We're the only area in town really that has true foot and ankle orthopedic specialists that are trained specifically in foot and ankle. We offer kind of all the options. We have specialists for every condition. And so if you've got more than one problem, it's not just your foot, but it's also your hip or your knee or shoulder. We have somebody that can really be an expert in treating that. We'll if you want to make an appointment, this is the number to call. You can make appointments, I believe now actually on the website. You can make them directly. But you can call this number. They'll be able to schedule an appointment with me or my partner who do foot and ankle surgery. We get plenty of openings now, so it's a good time to get in and be seen. If you want to be seen right away, we're always available. Um, we really do find that for this problem it can be quite debilitating, and we've got the options to treat kind of from the very beginning, non-operative treatment or more definitive treatments with surgery. Arthritis can be a tough problem because it is a chronic condition, so it doesn't go away. There's really nothing we can do to make it magically disappear. And there's no medication that'll solve it. There are medications that can help with pain. There are injections we can do to provide relief, but ultimately, most arthritis, it needs something done at some point. Um, Now, that being said, it does, by definition, get worse on an X-ray, but it doesn't necessarily continue to get worse from a symptom standpoint. So mild arthritis on an x-ray can hurt severely, and severe arthritis can be very mild symptoms. So it's there's a lot of options that we can offer. Um, and that's about it for my talk. I don't know if we have any questions, but if they do have any questions, I'm happy to try to answer those.
Dr. Krautmann, I don't believe there's any questions, so thank you very much.
Okay,
All right, everybody, thanks for joining.
thank you.